So now we like to begin with the second part of the second session, that is arthritis in children, which is being sponsored by Pfizer. I would like to invite Dr. Sujata Sawhney ma'am, pediatric rheumatologist, Sri Gangaram Hospital, Delhi, to talk on uveitis in childhood inflammatory arthritis. To chair this session, I would like to call Dr. Bharat Panigrahi sir, senior rheumatologist, Capital Hospital, Bhubaneswar, Dr. Arthabandhu Naik sir, senior pediatric consultant, ex-director of Health and Family Welfare, and Dr. Sujata Sawhney sir, professor and HOD, Department of Pediatrics, High Tech Medical College, Bhubaneswar.
Okay, so good morning to all again. So we will be starting the next session, that is the arthritis in children. And the first speaker will be none other than Dr. Sujata Sawhney. And all of us know she is an eminent pediatric rheumatologist of the country. And she will be talking on uveitis in childhood inflammatory arthritis. So you see, whatever uveitis is found in case of childhood, almost around 40% are due to these associated with inflammatory arthritis, and it is an very serious complications of this inflammatory arthritis. So let us hear from Dr. Sujata regarding the details of inflammatory arthritis in associated uveitis.
So good morning everybody, and it's such a pleasure to be here this morning. I'd like to thank Debashish for giving me the opportunity to talk to you today. So the topic before me is uveitis in childhood inflammatory arthritis. And really we all know, the audience here knows, that children who develop uveitis in the context of juvenile arthritis have two types of uveitis. One is the acute anterior uveitis, where the child presents to you with flaming red eyes. And that is, so the acute red eye occurs in the context of the patient with enthesitis related arthritis. These children have an acute episode of uveitis that is obviously symptomatic with the red eye. There is pain, there is photophobia. It can be unilateral or bilateral, and very seldom does it go into chronicity. And we're not discussing that uveitis today. What we are going to discuss is the child who presents with a silent chronic anterior uveitis. Now really you don't want to see the child with an absolutely damaged blind eye as on the left side, nor do you want to see a child with hypopia and uveitis, nor do you want to be able to shine the torch and look at the eye with that light and say the child has uveitis, because in all these patients you've actually missed the boat. Because once you see posterior synechiae and cataract with the naked eye, then the patient has complicated disease, and that dramatically worsens the outcome. So before you want to discuss about childhood arthritis and uveitis, we really need to understand the pathogenesis, and herein lies the problem. We don't have a cure for any of these diseases because the pathogenic mechanisms are not extremely well elucidated. I always tell my fellows who come for any training with me that if you are asked a question on pathophysiology, you can always pick up the burette and you can say that you have a genetic predisposition with particular infections in a programmed environment and an aberrant immune response. And that holds true for everything. So if you begin with that, for many complex reasons we don't know why, the uvea is attacked and the child can develop a significant inflammation. Now what is well understood is that one of the main cytokines that drives this inflammation is TNF, and therefore adalimumab seems to be the go-to drug when we run into difficulty. There's more data coming out on the genetics, and it is noted that children, especially girls, who have this particular YST motif in the DRB1 gene, the girls are more prone to develop uveitis. In the context of an oligoarticular patient, an elevated ESR and S100A12 high levels are children who are more likely to develop uveitis than not. Rituximab is not a go-to drug for children with this particular kind of uveitis. It's intriguing because these patients who develop the uveitis are in fact ANA positive, and the ANA is produced by the B cells, right? But there are some trials which are showing in adult non-infectious chronic anterior uveitis that rituximab is effective. And we don't have any class 1 trial on rituximab in these particular patients. If you look at the early literature from India, I'm audible, it's okay. Audible nahi hai? Kya kar raha hai? It's okay, मैं जोर से बोलते. So when we look at the data from the older studies in India, we learned that uveitis in the context of juvenile arthritis did not occur. We've looked at our own data in 2022. We were following 148 children with uveitis, of which a substantial portion were children with juvenile idiopathic arthritis. In 2022, we were following more than 1,000 children of juvenile arthritis, and our incidence of uveitis is 4.4%. If you look at the world literature, it's from 5 to 19%. Why are we lower? We are lower because the maximum number of patients we see of juvenile arthritis belong to the enthesitis related arthritis category, and we have about more than 40% of patients who have enthesitis related arthritis, and the incidence of uveitis in the ERA subcategory is 14%. Chronic anterior uveitis in the whole cohort is 4.4%, and if you look at the children with oligoarthritis in our unit, 22% of them, 1 in 5 develops uveitis, and that's a big number. So 1 in 5 with oligoarticular in our center develop uveitis, and we don't have a single child who's seropositive and has uveitis. We have one child with systemic arthritis who had very difficult to control uveitis. So uveitis does occur in India. The features are chronic, silent, anterior, non-granulomatous. Which is the patient most likely to get it? It's complex. It depends upon the age of the patient. Less than 6 or 7 years is more likely. The ANA status, more likely if you're high titer ANA positive. The sex, more likely in girls, but boys have a worse outcome. If you are rheumatoid factor positive, you are protected from the uveitis. And the longer you go from the diagnosis of arthritis, the less at risk you are of developing new onset uveitis. So these are all very, very important things to note. The highest risk in the first 4 years, 10% of children will develop uveitis after 4 years, and there are case reports in literature of uveitis developing for the first time even after 10 years. So the screening relies upon all of these characteristics, and you can go ahead and look at the screening guidelines of SHARE and the ACR. They are all pretty much similar except for the cutoff age of 6 or 7 years. The only organization that suggests 2 monthly uveitis screening in the first 1 year is the BSPAR from UK. So this is all very well for the pediatric rheumatologist, but what about the poor ophthalmologist who's sitting in the periphery, who has to decide how quickly and how frequently should I see these patients? So this is new new data which has come out suggesting that for the ophthalmologist, you simply have to look at the age of onset of the disease. Don't worry about the subcategory. In the first year, look at the patient every 2 monthly, and then depending upon the risk categorization and the age of the patient, you can increase the interval of screening. And this has been replicated also in the ACR screening guidelines of 2019. You need a very comprehensive report from ophthalmology. So you need a person who is interested and who has patience. You want to know not only the status of the anterior chamber, that is the cells and the flare, but you need to know the vision, the pressure, the complications, sometimes the wide field angiography, and also the OCT. So you need a very comprehensive evaluation. When you want to evaluate the anterior chamber, you must have your ophthalmologist looking at what is called the sun grading, which gives you the severity of the flare and also the number of cells. So your machine and man are both very important, because if you have a very basic entry level slit lamp, you're not going to be able to work with that very effectively. So you need to have a good ophthalmologist with a great machine to get on to how severe is the inflammation. The standard teaching has always been that the uveitis and the arthritis march on their own tune. That is to say, both may not go in parallel, but there's some data to suggest that if your patient has an articular flare, then that child is at high risk of developing new onset uveitis or uveitic flare within 6 weeks from the arthritis. So what is the practice point? If your patient has an articular flare after a long while, please get the eyes evaluated within 6 weeks. So what about the protection of methotrexate for uveitis? There's excellent data from Netherlands to show that if your patient is on methotrexate for the arthritis, the risk of developing uveitis is much lower than if the patient is not on any conventional disease modifying agent. The dose of methotrexate doesn't matter a lot, so whether it's 10 or 15 milligram, the survival probability of not developing uveitis is much higher in the group of patients who are on methotrexate. What are we doing today? For the oligo patient, the commonest joint is the knee. We are giving an intra-articular injection, we are forgetting about it. Is that a wrong paradigm? Should you actually be using, in fact, low-dose methotrexate for that patient? Because developing uveitis is morbid and it's lifelong. So maybe we aren't really following the correct practice as of now. What if you discontinue the methotrexate for arthritis? Those children are at high risk of developing uveitis within the first 1 year, and that can continue up to 4 years after discontinuing methotrexate. So even if your child is 5 years of age, had arthritis at the age of 1, was put on methotrexate and does not have uveitis, question, should you be discontinuing methotrexate or waiting? Very important questions which we have really not addressed to date. All over the world, it's been shown that the use of methotrexate and anti-TNF have reduced the incidence and the severity of uveitis. And can you see that if a child is on a combination of methotrexate and adalimumab for the articular problem, the risk of developing uveitis is very small, very small. So are we following the right paradigms of management? Because for no condition other than this is it absolutely appropriate that prevention is better than cure. We have to try to prevent the child from developing uveitis, and right now we're all like cats trying to catch our tail, and we are chasing the uveitis and giving one drug after the other. So the goals of treatment are very clear. No inflammation in the anterior chamber, no use of steroid, either topical or systemic, and definitely the use of depot steroid injection intraocular is virtually ruled out in the year 2024. The care has to be individualized. What does it depend upon? The age of the patient, the disease severity, the presence of complication or not, and whether the joints are swollen or not. And beware of the young child under 7 who is not able to see because of any particular reason. That patient is at risk of amblyopia. And if you have amblyopia, you're cerebrally blind and you get that eye to be normal, that child will never see. So you have to be conscious about the age of the patient. You're aware about the topical agent. It's got to be steroid and a mydriatic to prevent the posterior synecdoche. Amongst the conventional synthetics, it's methotrexate. In the biologic, it's adalimumab. If adalimumab doesn't fail, you're in trouble. So what about the steroid use topically? There's excellent data to show that if you use more than 2 drops of steroid for more than 3 months, you dramatically increase the complication risk in these patients. So please don't do that. If your patient is requiring more than 2 drops for 3 months, you need to add a synthetic DMARD. Which DMARD? Methotrexate. Pool data, what does it show you? Efficacy of methotrexate in the proper dose is 73% for managing uveitis. What if the patient doesn't respond to methotrexate, or you want to layer an anti-TNF with methotrexate? Occasionally we have 2 trials. We have the Adjuvite trial. This is from France. It's very easy to comprehend. You basically look at the sun classification at 2 months and you use a very sensitive outcome measure with a laser flare photometer, and adalimumab is hugely effective. You come to the Sycamore trial. I think I've got an attenuation of gray cells. The outcome is very difficult to understand. Very difficult to understand. It's freedom from treatment failure. Okay? But treatment failure is presence of uveitis, and then you have the survival curves which are very complex to understand. But suffice it to say that with the statistical modeling, the drug was so effective that the trial had to be terminated. Had to be terminated before the total number of patients, which was deemed to be 122, completed the study. So adalimumab is extremely effective. What about the other anti-TNF therapies? There's pool data to show that adalimumab is effective in 87%, infliximab in 72%, Etanercept is not effective in management of chronic anterior uveitis and should not be used. If your patient is on etanercept for arthritis and develops uveitis, you should switch the anti-TNF to adalimumab. How do you manage these patients? There are two models of care. One is a sequential model where you're layering one drug given for an X amount of time and then adding a second or a third. And the other one is you're using upfront. Upfront use of adalimumab and methotrexate is certainly the suggested method if your patient has complicated uveitis. Does etanercept increase the risk of developing uveitis? The BICR registry, which is a biologics registry, a pan-German registry, shows that there is no added risk of etanercept for the patient to develop uveitis. However, there is no comparison of children on etanercept versus adalimumab. In our own unit, we don't have a single patient on adalimumab who is ANA positive and has arthritis who develops uveitis. So in our unit, if we have high risk patients of uveitis and we need an anti-TNF, we'll always use ADA and not etanercept. What about JAK-STAT inhibition? We have the Juve-Bright phase 3 trial which shows the primary endpoint was not met. What about anti-IL-6? Anti-IL-6 was tested in a phase 2 study. The primary endpoint was not met and there's no phase 3 data available for this drug. Now looking at all this information, this evidence available, the SHARE and the ACR guidelines are well published and you could go back and check on them, and there's an update on the guidelines of SHARE of 2023. Essentially, the screening is changed to 2 monthly for the first 1 year, and there is some clarity. If the patient does not respond to adalimumab, then what do you do? And that has been synthesized in this treatment pathway. That is to say, a patient on your left who does not have complicated disease and a patient on your right who has complicated disease. I think one thing we sorely miss in our country is the availability commercially of adalimumab drug level and anti-adalimumab antibody. If we had that availability, we would be able to understand what to do if the child does not respond to adalimumab. There's a review article just recently published a couple of months ago which suggests that if the patient flares on 2 weekly adalimumab, the first thing you should do is move to weekly adalimumab. If patient doesn't respond to weekly, move to infliximab. No success, move to anti-IL-6. No success, move to tofacitinib or rituximab. No success, proceed to the Jagannath temple. What about our own data? We've looked at the use of drugs in chronic anterior uveitis, and this was a 5-year data. I'll take less than 1 minute. And this was a 5-year data. All our patients were on methotrexate at the end of 5 years, and 40% were on adalimumab. And Prajakta presented the work from our unit on the use, on the outcome of children at the end of 5 years, and we were able to show very nicely that our visual outcomes are very good. We have 86% of children who have visual outcome of 6.6 to 6.9 and 14% at the end of minimum 5 years who have a lowered visual outcome. Outcomes are somewhat worse in the child without arthritis as compared to the chronic anterior uveitis. And when we look at the factors affecting uveitis in a multivariate analysis, male sex and complicated disease throughout the cohort and for the GII uveitis had a worse visual outcome as compared to the females who had no complicated disease. So to conclude, juvenile idiopathic arthritis uveitis is a significant clinical burden. Teamwork is extremely essential. Intensive screening, especially in the first few years, is critical. The control of inflammation directly guides long-term visual outcome. We should not be dependent on topical steroids, and we've tried to challenge a few old dogma, that is the uveitis and arthritis don't go together. If the patient has a late arthritis flare, definitely can have a uveitis flare. Should oligo patients with only knee disease be treated with intra-articular steroid? Maybe we are doing wrong by them. So thank you so much.
Thank you, Dr. Sujata, for your nice talk. So friends, it's a very important topic, and since the asymptomatic nature of the uveitis, except the JIA, that is the anthracite uveitis, so we should be very much cautious because most of them will present with complications as she has shown. So we must be very much aware that. So all these JIA should be screened as far as the latest consensus guidelines she has shown. So we should screen all the patients at least for the uveitis. So any one or two questions from the audience?
So if the patient has CMV, again you have to look at the vision. So if the vision is down with CMV, we will give pulsed methylprednisolone and start the child on methotrexate and see how that patient does. Sometimes the CMV comes down very quickly, you don't need to go further. There's some data that anti-IL-6 is better for CME, but occasionally only. A lot of the CME comes down very quickly with pulse steroid. It's only if it's persistent, recalcitrant, with visual impairment that will you want to use a biologic like anti-IL-6.
Simple question. Someone who's not affording the role of tofacitinib in uveitis, which seems to be coming up slowly but steadily, and drugs like MMF, cyclosporin, I don't know if I missed that part of the talk.
So if a patient is not responsive to methotrexate alone and cannot afford, currently in our unit, we prefer addition of mycophenolate than tofacitinib. All the children that we've tried on tofacitinib have failed.
And methotrexate plus MMF.
Just a small comment. Although GI ERA patient mostly present with acute uveitis, around 20 to 25% of them can have an association with the posterior uveitis. So always ask for a B scan during the initial time to avoid ignoring this posterior uveitis, because they are the bad uveitis and they have to treat it early.
Absolutely. So whether or not the patient requires an OCT, we leave to our ophthalmologist. So if the posterior chamber is absolutely clean, then we don't go ahead with OCT. But if there's any doubt, especially with a vitreal haze, we would always do an OCT on the children.
And aggressive on treatment.
Absolutely. So the SPA patient developing uveitis is a factor of the time. So the longer they have the SPA, the higher risk of uveitis. So because we look after children, the risk of uveitis is different as compared to the adult population.
Sujata, for me the scariest thing that the ophthalmologist can tell me is ciliary body hypotony. That is the one thing where most of the time, whatever you do, the patient is less, the prognosis is going to be very guarded, visual prognosis. Do you agree?
Absolutely. So when we talk of complicated uveitis and you look at prognostic features, hypotony is a huge one, including phthisis bulbi, hypotony, cataract, visual impairment, they all come under poor prognosis.
I thought SJI did not need any screening for uveitis.
Once a year. Once a year.
Okay, so welcome. Thank you, Dr. Sujata.